In chapter 36, we'll talk about gastrointestinal disorders. And the first gastrointestinal disorder we'll talk about is dysphagia, which means a difficulty swallowing. And this could be an inability to initiate swallowing or the sensation that swallowed solids and liquids will stick within your esophagus or pharynx. It can also be associated with pain while swallowing, which we call odonophagia. And what this slide shows then are some of the different causes of dysphagia. So we can see that fibrosis or narrowing of the esophagus can make it difficult to swallow. External compression due to a tumor can also lead to dysphagia, or the formation of a diverticulum. And a diverticulum is essentially where the layers of the wall of the esophagus start to separate, and then material kind of starts to lodge within those layers, and it forms this sort of undigested pouch that you find that can obstruct the esophagus, and that itself can lead to dysphagia. Otherwise, there could be some congenital anomalies as well. Like for one, there's where the esophagus and the stomach fail to develop and connect. So what happens here then is the esophagus kind of just dead ends and it doesn't connect to the stomach. This is one of those congenital anomalies called congenital atresia. Now, another form of congenital anomaly that can lead to dysphagia is a tracheoesophageal fistula, where the trachea and the esophagus might be fused together, and this could lead to the condition where if someone swallows food, then some of that food can end up in the trachea, and that can initiate a coughing reflex that also makes it difficult to swallow. Otherwise, neurological damage can also make it difficult to swallow. Damage to nerves like 5, 7, 9, 10, and 12. 5, 7, 9, 10 are all part of your parasympathetic nervous system. These are nerves that are necessary for swallowing and digesting. And then cranial nerve number 12 is the hypoglossal nerve, which connects to your tongue. So if your tongue can't participate in the pharyngeal phase of swallowing, then that can also make it difficult to swallow. So neurological disorders can also lead to dysphagia, as well as achalasia. And achalasia is basically where you have sort of a widening of the esophagus, and it's a place where food might collect, and that itself can also make it difficult to swallow. Now, esophageal pain or heartburn can be caused by a variety of things, but for one, it's typically caused by reflux of gastric contents into the esophagus. And what happens here is that due to failure of the lower esophageal sphincter, you have high acidic content, chyme, that ends up kind of irritating the sensory endings in the mucosa of your esophagus. This can lead to spasms of the esophageal muscle, as well as heartburn itself due to burning of that through those acidic fumes. Some of the clinical manifestations of heartburn will be things like substernal burning and the sensation that can radiate through your neck and throat. And often heartburn can be confused with things like angina pectoris or even heart attack because they can have a similar sort of feeling. The difference, though, and the way you can differentiate between heartburn versus like angina pectoris would be that the pain here worsens while swallowing. If it's heartburn, while swallowing, it will not change, angina pectoris kind of pain. Now, chest pain in general can be caused by things like esophageal distension. This can arise from like obstruction of the esophagus or spasms, or even infections of the esophagus as well. Now, the clinical manifestations of this kind of esophageal pain, they're similar to angina pectoris. Like I said, it radiates to the neck, shoulder, arm, and jaw, but swallowing will generally worsen the sensation of heartburn or chest pain, and therefore that's one way you can kind of clinically differentiate between esophageal pain and angina pectoris. Now, abdominal pain can be one of the first signs of a GI tract disorder or other disorders, and we can differentiate between different types of abdominal pain. We got visceral versus somatic abdominal pain. If it's visceral pain, it's more diffuse and poorly localized. It's going to be kind of like a gnawing, burning, cramping type of pain that can come from inflammation or distension of abdominal organs. And this differs from somatic pain because somatic pain is more of a sharp, intense pain that's very well localized to the site of irritation. Like an example of somatic pain could be, a pain in the sigmoid colon that's due to maybe an obstruction or gas accumulating in the sigmoid colon itself, which could be kind of like a sharp or intense pain. And that it's different from visceral pain because visceral pain is more diffuse and poorly localized, and it's more of like a burning kind of pain. Now, referred pain is a type of pain that's felt in a location that's distant from the source of that pain. Now, the reason why this arises is that it occurs in the same dermatome or neurosegment as another area of your body, so that what happens here is that pain in an abdominal organ might actually be felt like pain that's sharp and well localized to a particular patch of skin or some deeper tissue. So if it's acute, we have instantaneous onset. If it's chronic, more gradual onset. And there's different types of referred pain that we'll come back to later. Now, in terms of intestinal gas, this can lead to a variety of clinical manifestations like belching, abdominal distension, and excessive flatulence. Belching can come about from swallowed air, but it may also come about from a motility disorder where if you get retropulsion of gastric contents, this can also lead to belching. Otherwise, abdominal distension can also lead to, or can also be a cause of abdominal gas. And this could be it's a condition where you have failure to adequately digest nutrients such as lactose. And if bacteria feed on those nutrients, then this can lead to excessive production of gas that can lead to abdominal distension. Intestinal gas can also lead to excessive flatulence, and it's basically just a lot of farting, and it's produced by bacteria. And so excessive consumption of things like legumes, vegetables, beans, basically non-digestible carbohydrates can be fermented by these bacteria, and they can produce an excessive amount of gas. Now, constipation is defined as small, infrequent, or difficult bowel movements with fewer than 3 stools per week. So that's about 1 stool movement every other day. And some of the causes of constipation could be things like a diet low in fiber or high in cellulose, so high in fiber. Lack of exercise. Aging can also slow the rate of peristalsis in your abdominal organs, or other pathological conditions that may alter motility, like diverticulitis, obstruction, or even hypothyroidism, because thyroid hormone controls GI motility, or basically smooth muscle in your gut. Now, the complication of constipation is fecal impaction, and if severe enough, this can be fatal. Now, diarrhea is actually going to be where you have increased frequency and fluidity of bowel movements, and this can be caused by a decrease in transit time in the small intestine. If it's acute diarrhea, then this might be caused by infection, emotional stress, or leakage of stool around impacted feces. If it's chronic, then we define this as lasting more than 4 weeks. This may come from a chronic infection or alterations in motility or integrity of the GI tract. Malabsorptive disorders, other endocrine disorders, food allergy, irritants, and caffeine can also all lead to chronic diarrhea. Now, in terms of some of the causes of diarrhea, we have osmotic, secretory, exudative, and as well as diarrhea caused by motility disturbance. Osmotic diarrhea is where, due to a malabsorptive disorder, if you can't absorb nutrients, then water won't follow. Water will follow those nutrients. So, by having more solutes left behind in your GI tract, then you'll have more water as well, and this leads to a form of diarrhea which we call osmotic diarrhea. So osmotic diarrhea will be like a nutrient and water-rich type of diarrhea due to decreased absorption of nutrients. Secretory diarrhea is actually due to toxins that stimulate intestinal fluid secretion, like Clostridium difficile can do this, and this can cause someone to lose up to more than 1 liter of fluid per day. In fact, the secretory type of diarrhea in the past was one of the leading causes of death in the United States and Europe. It's still one of the leading causes of death worldwide. Now, for the exudative type of diarrhea, it could be due to mucus, blood, or protein. And this can result from inflammatory processes where an excessive amount of mucus, blood, or protein in stool can cause diarrhea. And you can also get diarrhea from motility disturbances. If someone has excessive contraction of gut GI muscle, then you see decreased transit time of chyme and therefore less time to absorb those nutrients, and this will also lead to diarrhea. Now, stomatitis is what we call an inflammation of the oral mucosa. Some of the causes of stomatitis include things like pathogenic organisms, trauma, chemical irritants, chemotherapy because the mucosa is not replaced as frequently if you're under chemotherapeutic drugs, exposure to radiation, nutritional deficiencies like scurvy or vitamin C deficiency, certain autoimmune disorders that can affect the oral mucosa, or could even be idiopathic. Now, acute herpetic stomatitis is caused by herpes virus, HSV1 or HSV2, and this is what causes cold sores or cankers. Now, some esophageal disorders include ones like GERD, which is a gastroesophageal reflux disease, and it's a backflow of gastric contents through the lower esophageal sphincter into the esophagus, and this can lead to inflammation and due to exposure to acidic material, which can lead to esophagitis. Now, some of the causes of GERD can be things like any condition or agent that can alter the strength or closure of the LES. Things like increased abdominal pressure, exposure to excessive amount of fatty foods, which can lead to excessive stomach distension, caffeine intake, large amounts of alcohol, because alcohol is a depressant. It can also depress the lower esophageal sphincter muscle. Cigarette smoking, pregnancy, or even anatomical features like hiatal hernias can also prevent adequate closure of the LES. Now, some of the common complications of GERD include Barrett's esophagus. Barrett's esophagus is where, due to chronic exposure of acidic fumes, the columnar tissue gets replaced with, columnar tissue is replaced with normal stratified squamous epithelium. And this columnar tissue, although it can protect against those acidic fumes better than the stratified squamous epithelium, this also increases the risk for esophageal cancer. Now, excessive exposure to the acidic fumes can lead to ulceration or even fibrotic scarring of the esophagus, which can cause esophageal strictures or narrowing. That itself can lead to dysphagia, but can also lead to a variety of pulmonary symptoms. Interestingly enough, those acidic fumes may actually travel so far up the esophagus that when you inhale, you actually start to inhale acidic fumes as well. And that can lead to things like cough, asthma, laryngitis from breathing acidic fumes from the esophagus. Now, hiatal hernia is where you have a defect in the diaphragm that allows a portion of the stomach to pass through the diaphragmatic portion of the thorax. And, we know that the esophagus has to pass through the respiratory diaphragm to get to the stomach. Now, the place where that esophagus passes through is called the hiatal hernia. It's a small little hole in the respiratory diaphragm for the esophagus to go through. But if that hole is distended, then it's possible then that the stomach can start to protrude up through the esophageal hiatus, and that portions of the stomach can start to be in the thoracic cavity just below the left lung. Now, some of the causes of this can be things like ascites, which is an accumulation of fluid in the abdominal cavity, or pregnancy, obesity, chronic striding, and coughing can also force the stomach up through the hiatal area into the thoracic cavity. This can lead to certain clinical manifestations like GERD, because this can actually place a lot of stretch on the lower esophageal sphincter, preventing adequate closure of that sphincter, causing things like heartburn, chest pain, and even dysphagia. Now, this is showing the different degrees of hiatal hernia. Normally what we should find is that the respiratory diaphragm is what separates the thoracic and abdominal cavities, and that the esophagus passes right through that respiratory diaphragm into the abdominal cavity, and that the stomach is actually located just nicely in the abdominal cavity. Now, with a sliding hiatal hernia, what we find then is that parts of the stomach can kind of slide up through this widened esophageal hiatus, and that portions of the stomach can now be found below the left lung. And then a paraesophageal hernia is where actually entire portions of the stomach start to protrude up into the thoracic cavity, and it forms a sac that's made of stomach, peritoneum, and they can be found in the mediastinal cavity just below the lung and kind of surrounding the heart as well. Now, inflammation of the stomach lining we call gastritis, and there's acute versus chronic gastritis. Acute gastritis could just be caused by ingestion of like different irritating substances like spicy food, food you might be allergic to, or even other irritating substances like alcohol. Chronic gastritis can be caused by Helicobacter pylori. H. pylori is actually a transmissible bacterium that's transmitted person to person, typically fecal-oral route, and you can also find it in certain water sources. But Helicobacter pylori is actually one of the pathogenic organisms that's associated with gastric ulcers. Now, the clinical manifestations of gastritis can be asymptomatic, but due to that inflammation, it may lead to things like anorexia, nausea, vomiting, postprandial discomfort, and if it's severe enough, it could lead to hematemesis, which basically means blood in the vomit. Now, what this is showing then is basically the a little bit of like a cartoon representation of Helicobacter pylori infection. Now, H. pylori has actually a lot of motile elements here. You find some cilia attached to this microorganism, and you can use these cilia to actually wiggle into the stomach mucosa. And it's here in the stomach mucosa it can kind of just feed on some of the nutrients you find here within the lining. Now, it thrives in acidic conditions, so the stomach's actually a very good place for H. pylori to be located. And although Helicobacter pylori doesn't release any exotoxins itself, this causes such a dramatic inflammatory response, you see loss of function, and that due to excessive inflammation, it causes ulcers to form. So gastric ulcers can be caused by Helicobacter pylori. What's interesting though is that not all gastric ulcers are caused by H. pylori, but many ulcers contain H. pylori. So it was implicated as a causative agent of gastric ulcers. Now, gastric ulcer disease is basically just disorders of the GI tract that can be caused by exposure to like excessive amounts of acid and pepsin, and these are digestive elements. So if you don't have as much mucus inside your stomach, acid and pepsin can start to degrade the stomach wall. Some of the causes of peptic ulcer disease could be things like too much non-steroidal anti-inflammatory use, stress, smoking, or genetic factors. Otherwise, H. pylori does play a kind of a key role in promoting gastric and duodenal ulcer formation. It thrives in acidic conditions, and although it makes ulcers kind of present, it also decreases the healing time of ulcers, which means you have a higher rate of recurrence. And clearance of this H. pylori does promote ulcer healing. So this is why they think that Helicobacter pylori is one of the causative agents of gastric ulcer. Now, what this slide is showing is actually just sort of the pathogenesis of these ulcers. And so, if you find a minor amount of erosion to the mucosa, this is just sort of a minor ulcer that might heal within several weeks. Otherwise, we have true and penetrating ulcers. A true ulcer is one which has gone through the mucosa, now into the submucosa and part of the muscularis. So that actually there's a lot of blood vessels and nerves that have been implicated. And because this ulcer is so deep, it's difficult to heal. And there's a lot of surface area for Helicobacter pylori to thrive and kind of eat different nutrients that are nearby. And then a penetrating ulcer can go actually through the muscularis, possibly even to the serosa. And then under really severe examples of penetrating ulcers, they actually might even penetrate the entire stomach wall, basically putting an entire hole through your stomach lining. And you can imagine these penetrating ulcers would be pretty painful. Now, what this slide is showing here is a endoscopic picture of a duodenal ulcer, and you can see that you get this little mucus layer here in the duodenum, and you can notice here this little area. There's an area of kind of darkened tissue, and it appears to be sort of inflamed in the surrounding area, and there's a lot of mucus being formed around this nearby area as well, because the mucus cells nearby are trying to protect this ulcer from potentially damaging chemicals, outside of that. So, what happens is the cells that surround this site of injury here can start to produce a lot of mucus to try to protect this tissue from further injury. Now, ulcerative colitis is a chronic inflammatory disease of the rectum and colon, and it's where you have large ulcers in the mucosal layer of the colon and rectum. It's associated with increased cancer risk because this chronic irritation can lead to metaplasia, dysplasia, and possibly even cancers. So that if someone has 7 to 10 years of ulcerative colitis, this puts them at a much higher risk of things like colorectal cancer. Now, you can tell this is ulcerative colitis here because you can see a lot of this sort of these areas of inflammation within the colon, and due to this inflammation, over time it can lead to dysplasia and possibly even cancer. Now, what we see here is another disease of the bowel, and regional enteritis or granulomatous colitis is what affects the proximal portion of the colon and ileum, and it's where you have chronic inflammation of all layers of the intestinal wall, and this results from blockage of lymphatic vessels. And with Crohn's disease, what we see here is that due to the blockage and inflammation of lymphatic vessels, you see widespread inflammation. And this doesn't only affect the colon, it can also affect the small intestine, which means that you can see a decrease in absorption of nutrients so that someone can actually get malabsorption of nutrients or even osmotic diarrhea from something like Crohn's disease. Now, Crohn's disease seems to have like an autoimmune etiology, but it may also be caused by exposure to chemicals that someone's allergic to. Enterocolitis is also called antibiotic-associated colitis or pseudomembranous enterocolitis. It's an acute inflammation and necrosis of the large intestine. It's caused by Clostridium difficile, and when it's exposed to antibiotics, when you kill off a large amount of Clostridium difficile, a lot of exotoxins released, and these bacterial toxins lead to things like diarrhea, particularly bloody diarrhea, abdominal pain, fever, leukocytosis, possibly even sepsis, or colonic perforation if the inflammation is severe enough, although this is more rare. Now, appendicitis is where you have inflammation of the vermiform appendix, and if left untreated, this can actually lead to rupture of the appendix, and that can lead to peritonitis and possibly even sepsis. Some of the clinical manifestations of appendicitis include things like periumbilical pain, because the skin around the umbilicus can start to have pain. That's actually the referred pain site for the the vermiform appendix. Or right lower quadrant pain. There's a McBurney's point, just sort of pushing on a particular area, and that can actually be painful. It can also lead to nausea, vomiting, fever, diarrhea, right lower quadrant tenderness, or other systemic signs of inflammation like C-reactive protein in the blood. Diverticular disease is actually the presence of diverticula or herniations in the colon. This leads to what we call diverticulosis, and it results from low dietary fiber intake and or high intraluminal pressure. This leads to the formation of these diverticula, and these can be asymptomatic unless they're inflamed. If they're inflamed, we call it diverticulitis. It can lead to fever, acute lower abdominal pain, and leukocytosis, and it's basically treated with antibiotics or even surgery for larger abscesses. So the diverticula are these basically little pouches that can form here, and kind of like the ones we saw in the esophagus, where there's a pouch of undigested food. Diverticula can actually be formed by foreign material kind of squeezing between layers of the colon wall, forming these diverticula, which, if inflamed, can form large abscesses that can be very painful. Now, next we'll talk about motility disorders. And what we see here is irritable bowel syndrome, and it actually occurs from alternating diarrhea and constipation that's accompanied by abdominal cramping and pain. And there's no identifiable pathological processes here, so we call this spastic colitis or irritable colon syndrome. The etiology of this seems to be unclear, but there seem to be genetic and environmental factors at play. Intestinal obstruction can be just partial or complete blockage of the small or large intestine, and it can be either mechanical or functional. If it's a mechanical obstruction, this can be due to things like adhesions of the bowel, hernias, tumors, impacted feces, Vovulus and Intussusception, which we'll talk about here in a minute, as well as functional obstructions, which are actually conditions that inhibit peristalsis. Like if someone's smooth muscle is paralyzed, that can be a functional obstruction of the bowel. Now, Oliglev syndrome is characterized by recurrent bouts of ileus, and ileus is where you just have paralysis of the bowel, although this is more rare. Now, volvulus is actually twisting of the bowel, and it's where the bowels kind of twist against each other, which causes a mechanical obstruction itself, physical obstruction. But this twisting of the bowel actually causes compression of blood vessels, which can lead to ischemia and necrosis of that bowel as well. This results from an anomaly of rotation or ingested foreign bodies that may cause adhering of the intestines. And the cause of this can't always be determined, but some common sites of this are the cecum and sigmoid colon. So this is an example of volvulus, where we see that the distal end of the small intestine, where the ileum meets the cecum, if this twists, then not only is that going to be a physical obstruction of the bowel, but also that due to the twisting here, that blood vessels can become pinched, and you can see downstream ischemia and possibly even necrosis of the bowel, which can lead to things like sepsis. Now, intussusception is actually where you have telescoping or invagination of the bowel, and it's going to be usually where you have proximal parts of the bowel sort of telescoping into the distal areas of the bowel. Occurs in infants and for some reason males more often than females. Now, the treatment for this is surgical treatment, but the reason why it needs to be treated quickly is that this can put someone at risk for things like gangrene, which can actually lead to septic shock, or even actually perforation of the bowel if it's not treated quickly enough. So we see here then is that the proximal areas of the bowel might just start to stick into the more distal areas of the bowel, so you get this folding of the intestinal tissue where they sort of telescope. And what's interesting here is that this telescoping bowel, if severe enough, may be up to feet in length, depending on how much bowel has been telescoped. And the reason why it's dangerous is that due to this sort of folding here, not only does it limit blood flow to these areas of the bowel wall, but because bacteria get trapped in here, they're not moving around very well, and it's more of an anaerobic kind of condition. It can make someone at risk for infection there as well, which can lead to gangrene and sepsis. Now, megacolon is a congenital or acquired condition where you see massive dilation of the colon. The cause of this can be prolonged constipation or pseudomembranous colitis. Now, this is a surgical emergency because the colon gets so large. This is an example here. You can see so much abdominal distension. And this example is a picture of it's a surgery where they went in and basically removed the entire large intestine from this individual. And just for reference, you can see here's a surgeon's hand, which is on the colon itself. And you can see how large the colon became as a result of all these impacted feces. And unfortunately, this patient didn't survive the procedure. Now, some malabsorptive disorders are basically just going to be any kind of disorder where you have difficulty absorbing nutrients. Some of the causes of this might be enzyme deficiencies or abnormalities, infection, radiation, mucosal dysfunction, surgical alterations that might affect transit time, or even a decrease in the absorptive surface area of the small intestine. Some of the clinical manifestations of malabsorptive disorders will be things like osmotic diarrhea and passage of inappropriately processed intestinal components. You can find a lot of nutrients in the stool. It can also lead to abdominal pain because bacteria can start to feed on those nutrients that haven't been absorbed, and that can lead to a tremendous amount of abdominal gas. Now, the first one we'll talk about here is called celiac sprue, and it's a familial intolerance to gluten, also called celiac disease, and it leads to inflammation and atrophy of the intestinal villi, which, because these villi increase surface area of the small intestine, if they're inflamed, you see impaired nutrient absorption due to this reduced surface area. And because you have less brush border enzymes as a result as well, you'll see that there'll be less degradation or digestion of your nutrients. So, this can lead to malabsorption and abdominal issues as well. Now, it also increases the risk for intestinal malignancy due to chronic irritation. You might see intestinal cancer as a result. Now, dumping syndrome is actually a syndrome where contents enter the small intestine too quickly from rapid gastric emptying. And what happens here then is that due to rapid absorption of a large amount of glucose, this leads to an excessive rise in plasma insulin, and so that this rapid increase in insulin also causes what we call rebound hypoglycemia, and by having low blood sugar, this causes basically things like nausea, vomiting, and just individual with really low blood sugar will have their a decrease in cognitive function. And this is common in people who've actually had gastrectomies or gastric surgery, because with a smaller stomach or no stomach, contents can enter the small intestine too quickly. You can get too fast absorption, and that rebound hypoglycemia can lead to nausea, vomiting. Short bowel syndrome here is going to be where, due to loss of parts of the bowel, you're going to see severe diarrhea and significant malabsorption, because most absorption occurs in the small intestine. That rapid transit time and reduced surface area for absorption not only will lead to malabsorption of nutrients, but also osmotic diarrhea. Now, we're going to wrap up here talking about neoplasms of the GI tract. And some of the neoplasm signs and symptoms of GI tract neoplasia are things like black, tarry, bloody, or pencil-shaped stools, or change in bowel habits. Some of the risk factors for your GI cancer include things like a low-fiber diet, high-fat diet, colonic polyps, or chronic irritation, inflammation. And the prognosis of the GI cancer is going to be related to the extent of spread throughout the body. And so early detection is associated with better prognosis. And surgical removal of tumors, followed by chemotherapy, is effective. Now, the first one we'll talk about here is esophageal cancer. It accounts for about 1 to 2% of all cancers, and you find it's occurring in men more than women. Some of the risk factors for esophageal cancer include things like genetic risk factors, Barrett's esophagus, what we talked about, smoking, as well as alcohol intake, because these are both irritants, but especially whiskey, because whiskey's made from charred oak barrels, and there are carcinogens in that charred oak, which get incorporated into the alcohol. And although it gives whiskey kind of a smoky flavor, those components actually are carcinogenic. So they can lead to esophageal and oral cancers. Now, the prognosis of esophageal cancer is more poor because of a very high degree of metastasis, and the esophagus is so well vascularized that cancers spread pretty rapidly. Now, the treatment for esophageal cancer could be like the placement of a stent to maintain the patency or openness of that esophagus. Otherwise, you might want to ablate the tumor through like a heat probe, laser, surgery, radiation, and chemotherapy can also be used to help get rid of that esophageal cancer. Now, gastric carcinomas are more prevalent in Japanese, and you find them in men greater than 30 years of age. But the 5-year survival rate is only 10% for gastric carcinomas. And the reason why it's presumably higher in Japanese is that due to a high salt diet, salt might irritate the gastric mucosa and put them at risk for gastric cancers. Now, the stages of gastric cancer, like all cancers, are really just determined by the degree of penetration, and particularly with respect to the stomach, how much penetration with respect to muscle involvement or lymphatic system involvement or even surrounding organs will give the degree and stage of that cancer. Now, small intestinal neoplasms can be benign or malignant, and they account for less than 5% of GI tumors, and you find these more common in people older than 50. But the clinical manifestations of this are going to be dependent on the type and extent of those neoplasms and whether this leads to partial or complete obstruction of the bowel. Obstruction of the bowel can lead to malabsorptive disorders, pain, nausea, vomiting, possibly even anorexia. So just depends on where the growth is that determines the clinical manifestation here. Colonic polyps were any protrusion into the GI lumen, and this is a major precursor lesion in the development of colon cancer. They can be benign or malignant, and they have different shapes here, like sessile and pedunculated. Sessile is going to be where you have a raised protuberance and a broad base. Pedunculated is where you have a kind of a stalk that's narrow at the body, and you have a wide sort of tip of the polyp. That's why it's pedunculated. And what this is here is more of a sessile polyp, where it just sort of protrudes outward. Now, these colonic polyps are one of the risk factors for cancer because it's a neoplasm. However, it's not necessarily malignant yet. But what decreases the risk then is by having these polyps removed if they do exist within the colon. Now, colon cancer is second only to lung cancer as the cause of all cancer deaths in the U.S. And some of the risk factors for this will be, after age 40, otherwise a high-fat, low-fiber diet. Think about like the traditional Western diet, high in fat but also low in fiber because we don't eat that many whole fruits and vegetables. Also, the presence of polyps or chronic irritation and inflammation can also put someone at risk for colon cancer, and genetic factors as well. Like if it runs in your family, then you're at a higher risk for colon cancer.